So how do we basically come to a conclusion? Now suppose a child is brought to us with stridor. That means the child is having noisy breathing. There is suprasternal retraction. So all the muscles which are responsible for respiration are overworking. So there is full effortful breathing when you see a patient like that, and when the oxygen saturation for the patient is very less. In that case, obviously first what we have to do is to secure the airway, but we also need to know the history. So what is the perinatal history? Has the mother been affected with any infections, or was there any history of neonatal intubation? Was the child on an incubator? And how is the stridor? Is it increasing or decreasing during sleep, or is there are different types of stridor which we will be dealing with very soon. So what is that pattern of stridor we have to see? How frequent is the stridor, or is it in relation to breathing? All these matters when we take the history. Secondly, we have to observe what character of stridor it is and what are the associated features. Say suppose the patient has associated asthma, then we should rule out other conditions. So that's what I mentioned in history, we have to know about the ventilation if the child was on any incubator. So premature children will be on incubator, they might need ventilation, so we might do an orotracheal intubation. So this is what we need to know. An orotracheal intubation means the intubation will pass from the oral cavity through the vocal cords into the larynx. So any child has very soft larynx, soft trachea. So any tube that we are going to insert through that is going to become a foreign body. So there is reaction of all the tissues to the foreign body, thereby causing fibrosis, and that can lead to stenosis. So if the stridor was present at birth itself, then we should think of laryngeal webs or subglottic stenosis that can happen because of congenital causes. During the first few weeks of birth, if they present, it could be because of laryngomalacia. Gradually, if it's increasing, then it could be because of obstruction from somewhere. So as I told before, what is its relation to rest and sleep? So if during sleep it's becoming better, then it could be laryngomalacia. If it becomes worse, that means why patient is lying down and you're breathing in and out, the polyp will go in and out. So in any pedunculated mass or micrognathia, in micrognathia we already saw that the mandible is pushed back. When you sleep, it's the oropharyngeal airway is more compromised. And then while feeding, if the stridor is increased, then it is definitely could be laryngomalacia. And sometimes when crying, in patients with bilateral choanal atresia, what is choanal atresia basically is choana, that is the posterior opening of the nasal cavity, is completely closed. So imagine when the child is crying and wants air to breathe, there is no air that can enter into the larynx. Sometimes the child may even become cyanosed because of lack of oxygen. So it can become that bigger emergency. So in relation to the feeding, so if related with breathing, we know bottle fed babies with air obstruction will come up for air. Bottle feed babies may require thickened feeds or slow treat. And if there is any aspiration, say suppose you are giving a fluid to the child, immediately the child is coughing, we should think of tracheoesophageal fistula or vocal cord palsy or any laryngeal cleft. If there is regurgitation, think of GERD or laryngomalacia. And how is the general medical condition of the patient? Is the child very emaciated, or is there any real acute obstruction? That means if after a meal the child is having all this, then it could be because of aspirated foreign bodies.